Hello once again, class, and a good day to everyone. So, here we are now on our final lecture for this semester regarding the management of patients with non malignant hematologic disorders. So, before we start out with the different disorders or blood disorders, we're going to study the frequently used lab tests in hematology. So, as you can see here, we have the different tests that are done, and usually, this test is done through complete blood count or other blood exams unless specified by the physician that are going to be done on patients who have suspected blood disorder. So we have the test there, the normal range description, and the indications of the different tests. So we start out with the RBC count. For males, the normal range should be at around 4.7 to 6.1 million cells per cubic millimeter. For females, it's 4.2 to 5.4 million per cubic millimeter. And of course, you all well know the function of hemoglobin. What do you call this? The RBCs. They carry hemoglobin, they carry oxygen, and the survival time is, or the lifespan of the RBCs is at 120 days. We also have the hemoglobin. For males, it's 13.5 to 17.5 grams per deciliter. For females, 11.5 to 15.5 grams per deciliter. What is the function of the hemoglobin? It's the one responsible for delivering oxygen through circulation to the different body tissues that we have, and it returns carbon dioxide from tissues to our lungs. A decrease in hemoglobin is an indication of anemia, but if there's an increase of it, it's an indication of polycythemia, meaning there's increased number of RBCs. Hematocrit for males, 40 to 52%. Take note of the unit, it's in percentage. For females, it's 36 to 48%. So this indicates relative proportions of plasma and RBCs, volume of RBCs per liter whole blood. And this one, it's usually three times that of the hemoglobin. What's the significance of the hematocrit? This signifies the percentage of the total red blood cells in the fluid, how it is suspended in that fluid. The greater the percentage is, means that the lesser fluid the blood has. But the lesser percentage the hematocrit is, means that the greater the fluid the blood has. So take note of that. We also have the mean corpuscular volume, or the MCV. It's 81 to 96 cubic nanometer. So this indicates the size of the red blood cells, and it's very useful in differentiating the different types of anemia. If it's less than 80, the cells are microcytic. They're small. If it's more than 100, that means that the cells are macrocytic or big. For the mean corpuscular hemoglobin concentration, the MCHC, that should be at around 33 to 36 grams per deciliter. So this is the average concentration of hemoglobin in the RBCs. And it is independent of cell size. So cell size does not influence this. Red cell distribution width, it's RDW, it's around 11 to 14.5%. It measures the degree of variations in the size of RBCs, while our reticulocyte count, 0.5 to 1.5%. It is the one that measures of marrow production of the RBCs or erythrocytes. 1% of the RBC mass is produced daily. So every day, our bone marrow, red bone marrow specifically, is producing 1% of our blood. in order to replace the 1% of old cells that die after 120 days. So this indicates the marrow's response to anemia if anemia is present. So when anemia is present, the reticulocyte level should rise. Now we go to platelets. Platelets is around 150 to 400,000 cells per cubic millimeter. So this is the total number of platelets in circulation. The average lifespan of our platelets should be around 7 to 10 days. If it's lesser than 200 or 20,000 cells per cubic millimeter, it's serious. That's already thrombocytopenia. And for less than 10,000, that's potentially life threatening. So the patient is going to bleed. Remember, the function of the platelets is to do blood clots, but without it, the patient is going to bleed. It can be brought about by dengue hemorrhagic fever or any other diseases that will lower down the platelet count of the patient. Thrombocytosis, however, is an increase in the number of platelets. So that would be more than 400,000 cells. For the WBCs or white blood cells, the cells per cubic millimeter is 4,500 to 11,000 cells. And if there is an increase of these cells, it means that the patient has an infection. Now we go to the prothrombin time or PT. It varies, but the average is 11 to 12.5 seconds. So this measures time elapsed until the clot will form, measures extrinsic and common pathways here. So this is increased in liver disease for patients who have disseminated intravascular coagulation or DIC, obstructive biliary disease, clotting factor depletion, and those who are using warfarin or Coumadin. Take note, warfarin or the brand name Coumadin will influence the prothrombin time. It will prolong it. For the partial thromboplastin time, the PTC average time is around 25 to 35 seconds. So surface active agent added to plasma, this measures time elapsed until clot forms. So it measures intrinsic and common pathways here. Again, there will be the indications of this is increase in clotting factor depletion. DIC, like the other from PT, liver disease, biliary obstruction, and if the patient is taking any anticoagulant such as heparin. Thrombin time or TT, it's 8 to 11 seconds. It tests conversion of fibrinogen to fibrin. So time to clot is inversely proportional to fibrinogen level. Fibrinogen, 170 to 340 milligrams per 100 milliliter. This is the one that measures or measurement of fibrinogen concentration within plasma available for conversion to fibrin clot. There are different types of clotting factors that you are going to learn. And the cascade of these clotting factors, if you remove one clotting factor, clotting will not occur because all of the clotting factors are important in the formation of blood clots. If there's one missing, that can lead later on to bleeding disorders. And we'll discuss more of that later on. So decrease in bleeding disorders, pregnancy, malignancy, and inflammatory disease. D dimer is around 0 to 0.5 micrograms per milliliter. This measures the amount of fragments of fibrin when it is lysed or broken down. Useful for distinguishing fibrinolysis from fibrinogenolysis. So this is increased with fibrinolytic activity, especially those who have rheumatoid arthritis and ovarian cancer. For fibrin degradation products, FDP, it's less than 10 micrograms per milliliter. It's a byproduct of fibrinolysis. More than 40 micrograms per milliliter would indicate disseminated intravascular coagulopathy. This is a disorder where blood clots will form in various parts of the body of a patient, which is very, very dangerous. Now we go to neutrophils. It's 40 to 75%, so around 2,500 to 7,500 cells per cubic millimeter. This is essential in preventing or limiting bacterial infection. Lifespan is around 2 to 4 hours. If it's more than 8,000, that's an indication of infection, most likely bacterial infection. Some inflammatory states, stress, steroids, other drugs, or myeloproliferative disease. The absolute neutrophil count ANC is less than 500. That is that will make the patient at increased risk for infection. ANC less than 100, infection is going to be certain. Lymphocytes, 20 to 50% of the WBCs, and 1,500 to 5,500 cells per cubic millimeter. This one is integral component of the immune system. So they're the ones responsible for our immune system. Less than 1,500 would indicate lymphopenia. More than that, more than 4,000, there is lymphocytosis. So it's increase in convalescent phase after bacterial or viral infection or in lymphoproliferative disease. Monocytes, 1 to 10%, so 100 to 800 cells per cubic millimeter. They're the larger types of WBCs that we can see. They enter tissues as macrophages and they do phagocytosis. Phagocytes, they eat foreign substances. So these are increased in acute and chronic infection, some myeloproliferative disorders, and chronic myelomonocytic leukemia or CMML. Eosinophils, one of the uh, granulocytes, it's 0 to 6%, so 0 to 440 cells per cubic millimeter. Take note, eosinophils are involved in allergic reactions. So, if the person has an allergy, the eosinophil count will rise. So, this neutralizes histamine, digest foreign proteins, so they are increased in allergic states. Medications, and if parasites are present, they will be increased as well. Or it's also increase in chronic myeloid leukemia or CML, metastatic or necrotic tumors. Basophils 0 to 2%, that's 0 to 200 per cubic millimeter. So it contains histamine, which is integral part of the hypersensitivity reaction. These also will be increased if there's an allergic reaction, but increase is very rare. But they are helpful in the allergic reaction. So next, we'll go now to the different diseases. Blood disorders. I'm sure you've heard of this before, iron deficiency anemia. So what is it? It typically results with when the intake of dietary iron is inadequate for hemoglobin synthesis. So it's the most common type of anemia in all age groups and is the most common in the world, affecting 1 in 8 persons. And the most common cause of IDA in men and postmenopausal women is either bleeding from ulcers, gastritis, inflammatory bowel disease, or any GI tumors. And the most common cause of IDA in premenopausal women are menorrhagia or excessive menses and pregnancy with inadequate iron supplementation. That's why it's very, very important for pregnant women to take iron supplements. Or those with who are chronic alcoholics, patients with chronic alcoholism or who take or abuse aspirin, steroids, or NSAIDs often have chronic blood loss from the GI tract, which will eventually lead to iron loss and eventual anemia. So, what are the clinical manifestations? Since iron is deficient, the oxygen which should bind with the iron component of the hemoglobin. So the oxygen carrying capacity of the blood is diminished if there's lesser iron. So if there's lesser iron, lesser oxygen is delivered, making the patient feel weak, feel too tired, or they have fatigue, and they are going to feel general malaise. So these are common signs or symptoms of having IDA. Pallor of the skin and mucous membrane. So if you check the skin, they appear pale. For dark-skinned individuals, you can check their mucous membranes instead, such as the conjunctiva or the buccal area of their mouth. If deficiency is severe or prolonged, the patients may have a smooth red tongue, and they might have brittle or rigid nails, and there is angular chylosis. So what are this? This is the type of tongue that the patients have, or patients with IDA have, and this is the angular chylosis that I have mentioned earlier. So there are lesions at the tips of their lips. This is rigid fingernails. So assessment and diagnostic findings. Remember, the definitive method of establishing the diagnosis of IDA is bone marrow aspiration that will confirm the presence of IDA. But decreased hemoglobin, hematocrit, and MCV in CBC alone can um, can diagnose that the patient has anemia. But the most definitive one is, of course, bone marrow aspiration. Medical management. So, anemia may be a sign of curable GI cancer or of uterine fibroid tumors. Stool specimen should be tested for clot blood. Clot blood meaning blood is present in the stools, but it is not barely seen by the eyes of the patient or the examiner. That's why it needs to be further tested inside the laboratory. People who are 50 years of age or older should have a colonoscopy, endoscopy, or other examination of the GI tract to detect ulcerations, gastritis, polyps, or cancer. And to manage this, of course, several oral iron preparations can be given, such as ferrous sulfate, ferrous gluconate, and ferrous fumarate. These are available for treating IDA. But take note, if you are administering fluid form of iron, make sure that the patient is going to use a straw when taking fluid forms of iron because this can stain the patient's teeth. So make sure that a straw is used. Fluid forms of iron can be mixed with orange juice. Take note, it is advisable for patients to eat foods that are high in vitamin C or take vitamin C supplements together with iron supplements to increase the absorption of iron because these two supplements they have a synergistic effect. Nursing management. So patient education is important here because IDA is common in menstruating and pregnant women. We also are going to teach our patients to eat foods that are high in iron, such as organ meats, beef or calf liver, chicken liver, and other meats. Beans, such as black, pinto, and garbanzo, are high in iron, or green leafy vegetables, raisins, and molasses. I've already mentioned the third bullet point here that vitamin C increases the absorption of iron. Okay, next one is Okay, the next one is we need to advise patients to take iron on an empty stomach because it is best absorbed on, or iron is best absorbed on an empty stomach. So we should advise patients to take it an hour before taking their meals. And some patients may have troubles or difficulties taking iron supplements because of its GI side effects, such as constipation, that's primary, also cramping or nausea and vomiting. So we are going to advise patients to increase their fiber intake. And like what I've mentioned, use a straw when preparing fluid or when taking fluid iron preparation of iron. So these are organ meats, green leafy vegetables. We should advise patients to eat those type of foods. Now we go to aplastic anemia. What is it? Aplastic anemia is a rather rare disease caused by a decrease or damage in the marrow stem cells. Damage to the microenvironment within the marrow and replacement of the marrow with fat. So this results in bone marrow aplasia, which is markedly reduced hematopoiesis. And therefore, what happens here is that there will be severe anemia. There will be decrease in RBCs, significant neutropenia, so decrease in the neutrophils or the WBCs all over, and thrombocytopenia, a deficiency in platelet. So pancytopenia. When we say pancytopenia, it means that all of the blood components are decreased because the bone marrow itself is the one that is affected here in this type of anemia. Aplastic anemia can be congenital or acquired, but in most cases they are idiopathic. So the cause of this type of anemia is unknown. Infections and pregnancy can trigger it, or it may be caused by certain medications, chemicals, or radiation damage. Agents that regularly produce marrow aplasia include benzene and benzene derivatives, such as airplane glue. Certain toxic materials, such as inorganic arsenic and several pesticides like DDT, which is no longer in use in the US, also have been implicated as potential causes of aplastic anemia. So just read these different types of substances associated with aplastic anemia. You can find them on your Bruner and Siddharth books. So you have different types of chemicals here. Even medications can cause aplastic anemia. Medical management. Since the bone marrow is the one that is affected, bone marrow transplantation or peripheral stem cell transplantation together with immunosuppressant therapy by giving anti-thymocyte globulin and cyclophosphamide will be administered to the patient, including blood transfusion if the patient needs it. So how is um, the peripheral stem cell transplantation done? Stem cells are collected from the patient's bone marrow over blood. The blood or bone marrow is processed in the lab to purify and concentrate the stem cells. Blood or bone marrow is frozen and in order for it to be preserved, and high dose chemotherapy, the ones I've mentioned, like cyclophosphamide, will be given. The thawed stem cells are reinfused back into the patient. So take note, bone marrow aspiration, bone marrow transplantation can be a very, very difficult experience for the patient. It's a painful experience. And if this happens, we should tell the patient what type of, what do you call this, procedure that they will undergo in order for them to expect the things that they are going to experience during this type of procedure. So here is an example of a bone marrow aspiration. What is our nursing management? Patients with aplastic anemia are vulnerable to problems such as related to RBC, WBC, and platelet deficiencies. So Since there is pancytopenia, you need to watch out for anemia, and they are also susceptible to infection. So we advise patients to do what? We advise them to avoid crowded places, always wear a mask, avoid raw foods. What else? Avoid people with obvious infection. And they have bleeding tendencies as well. So they should avoid contact sports, avoid using a razor blade when shaving, avoid going barefooted because of they might be wounded going barefooted. So check for signs of bleeding as well. Next, we have megaloblastic anemia. So what is megaloblastic anemia? It's caused by deficiencies of vitamin B12 or folic acid, and there's identical bone marrow and peripheral blood changes occur because both of these vitamins are essential in the normal DNA synthesis. So a bone marrow analysis reveals that there is hyperplasia or abnormal increase in the number of cells, and the precursor erythroid and myeloid cells are large and they appear bizarre. Many of these abnormal RBCs and myeloid cells are destroyed within the marrow. However, the mature cells do not leave the marrow. They will appear fewer in number. Thus, pancytopenia will occur, which is a decrease in all myeloid-derived cells. I've already mentioned what pancytopenia is earlier. In advanced situation of this disease, the hemoglobin value may be as low as 45 grams per deciliter. WBC count will be 2,000 to 3,000 cells per cubic millimeter, and platelet count is less than 50,000 per cubic millimeter. So those cells that are released into the circulation, they are appearing abnormally shaped. The neutrophils are also hypersegmented. Platelets may be abnormally large as well, and RBCs are abnormally shaped, and the shapes may vary widely, or this known as poikilocytosis. Because the RBCs are very large, the MCV is also very high, usually exceeding 110 cubic micrometer. So here, this is the normoblastic or the normal cells found in a patient with a normal um, blood cells. While for megaloblastic, as you can see here, they are enlarged. That's why they call it megaloblastic because of the enlargement of the blood cells. So there. As you can see here, the neutrophils in megaloblastic anemia is hypersegmented, unlike that of the normal one. Causes, there are two types of causes. It's either folic acid deficiency. This occurs in people who do not eat or who rarely eat vegetables. That's why class, it's very, very important for you to eat vegetables, especially the green leafy ones. Vitamin B12 deficiency can occur in strict vegetarianism since vitamin B12 is obtained through eating meat. So this can also be the consequences of being a vegetarian. Another cause would be the inability of the patient to produce the intrinsic factor in the stomach which binds to vitamin B12. That intrinsic factor in the stomach when is needed by the vitamin B12 which is obtained through diet in order for it to be absorbed. So this type of anemia is now known as pernicious anemia. So clinical manifestations, this the typical signs and symptoms of anemia will be present, such as fatigue, malaise, pallor. What else? Bleeding may occur since there's pancytopenia. Infection is common if the patient with this type of anemia is not cautious enough. So They will appear extremely pale, particularly in the mucous membranes, and patients with pernicious anemia develop a smooth, sore, red tongue, and mild diarrhea. They may become confused. More often, they have paresthesias in the extremities, which is the numbness or tingling sensation in the feet or lower legs. So, Tagalog, ito yung parang nakukuryente, yung mga extremities nila, lalo sa may paa. They also may have difficulty maintaining their balance due to damage to the spinal cord, and they will lose position sense or proprioception. So, this can happen. They will lose their sense of balance. Assessment and diagnostic finding. Classic method of determining the cause of vitamin B12 deficiency is the Schilling test, wherein the patient receives a small oral dose of radioactive vitamin B12, followed in a few hours by a large non radioactive parenteral dose of vitamin B12. This aids in renal excretion of the radioactive dose. If the oral vitamin is absorbed, more than 8% will be excreted in the urine within the next 24 hours. If no radioactivity is present in the urine, i.e., the radioactive vitamin B12 stays within the GI tract, the cause is GI malabsorption of the vitamin B12. But if the urine is radioactive, the cause of the deficiency is not ileal disease or pernicious anemia. So take note, if the radioactivity or the radioactive vitamin B12 is not present in the urine, there is GI malabsorption. So that would indicate that there is pernicious anemia. But if it's present in the urine, that is not pernicious anemia. Later, the same procedure is repeated, but this time intrinsic factor is added to the oral radioactive vitamin B12. Is radioactivity is now detected in the urine because of the presence of that intrinsic factor. It means that B12 was absorbed from the GI and in the presence of the intrinsic factor. The diagnosis now of pernicious anemia can be made. Another useful earlier test is the intrinsic factor antibody test. A positive test indicates the presence of antibodies that bind to the vitamin B12 intrinsic factor complex and prevents it from binding to the receptors in the ileum, thus preventing its absorption. What are the medical management? Folate deficiency is treated by increasing the amount of folic acid in the diet by administering 1 milligram of folic acid daily. Vitamin B12 deficiency is treated by administering vitamin B12 replacements. Vegetarians can prevent or treat deficiency with oral supplements through vitamins or fortified soy milk. When it is more common, the deficiency is due to defective absorption or absence of intrinsic factor, which is the pernicious anemia. Replacement is by monthly intramuscular injections of vitamin B12, usually at a dose of 1,000 micrograms. YIM injection. Remember, their GI for patients with pernicious anemia, their GI tract cannot absorb vitamin B12 due to lack of intrinsic factor. The reticulocyte count will rise within a week, and in several weeks, the blood counts will become normal. So for folic acid deficiency, we just need to teach patients to increase their green leafy vegetables. For B12 deficiency, they should take B12 supplements. Nursing management, the nurse needs to pay particular attention to ambulation and should assess the regular patient's gait and stability, as well as the need for assistive devices such as canes, walkers, and for assistance in managing daily activities, since some of these patients can lose their sense of balance. If sensation is altered, patients need to be instructed to avoid excessive heat or cold, especially when taking a bath. Because mouth and tongue soreness may restrict nutritional intake, the nurse can advise patients and families to prepare bland, soft foods to eat small amounts frequently. So we need to offer small, frequent feeding due to tongue or mouth soreness because they might lose their appetite because of the soreness that they are feeling. Patients may also be taught about the chronicity of their disorder and the necessity for monthly vitamin B12 injections, most especially for pernicious anemia, even in the absence of symptoms. Many patients can be instructed to self administer their injections. Okay, I'll stop there for a few moments and continue our lecture with sickle cell anemia. So please wait for my next video with regards to sickle cell anemia and the rest of the other blood disorders. Thank you everyone for listening. So stay tuned for the next set of video.